Okay, so here it is, time to get started with week one, lecture one. This first week is the stuff that is more, it seems more, I guess, removed from an actual patient scenario or patient population. And for that reason, it can be a little bit harder to get your hands around. But this is the basic language of pharmacology, pharmacodynamics, and pharmacokinetics. And in order to really be able to have a dialogue about how we select drugs to treat diseases and the impact that they can have on the patient, on other disease processes, the impact that drugs can have on each other, we really do have to start from a place where these foundational terms, they're well defined, they mean something to you. I mean, it's like anything else. If you want to speak the language, you have to start out with the alphabet. And basically, this week is about the alphabet of pharmacodynamics and pharmacokinetics. So there are two YouTube videos this week. The first one is the longer one. The second one has some information about special populations and then a case study that hopefully will make things a little bit more clinically relevant and applicable for you. But before we get there, we have to start with good old-fashioned terminology. And so some terms that, again, I know it's there's a tendency to like want to memorize everything and be able to recite it back. And true, there are definitely some things here that you just have to remember. I mean, there's no getting around it. But rather than just be able to say a term and recite a definition, I hope that you can really begin to think about what it actually means, what we are really talking about when we use some of these terms. For instance, pharmacodynamics is very commonly used in the world of the prescriber. And pharmacodynamics is very simply what the drug does to the body, what you are doing to the disease process when you give a drug, and what you might be unintentionally doing to other processes of the body. So some examples of pharmacodynamics are you probably, well, I know everybody is here from different specialties, and so I guess I don't want to make any assumptions, but like some very commonly used drugs in general medical surgical nursing are, for instance, a beta blocker. Drugs like propranolol, atenolol, metoprolol, carvedilol. There's a bunch of beta blockers out there, and we throw around the term beta blocker all the time. But beta blockade or beta adrenergic antagonism is the pharmacodynamics of that drug. And what it does is block beta adrenergic receptors. And so beta adrenergic receptors are receptors that are distributed all over the body. They are largely activated by epinephrine. And when epinephrine binds to a beta receptor, it causes a response. Like, for instance, in the heart, it increases contractility and increases rate. In lung tissue, when epinephrine binds to a beta receptor, it causes smooth muscle relaxation and bronchodilation. But the pharmacodynamics of the drug, beta blockers, is that it blocks those receptors. So if you give someone a beta adrenergic antagonist, commonly known as a beta blocker, that drug blocks beta receptors so that epinephrine cannot bind to them and do what they do. And that's the pharmacodynamics. And pharmacodynamics doesn't change across the lifespan. It's the same pharmacodynamics to a 2-day-old baby or a 1-year-old or a 10-year-old or 20, 30, or an elderly patient. Pharmacodynamics is the same across the lifespan. To complete the example, remember we also have beta adrenergic agonists. Beta agonists are drugs that activate beta receptors, like albuterol that we commonly give to people that are having an asthma attack, epinephrine that we give to people that are having anaphylaxis. So that's an example of pharmacodynamics. Pharmacokinetics is a little less straightforward because we don't think about it in everyday terms at the bedside nursing level. But pharmacokinetics is what the body does to the drug. Remember, the basic principle of the human body is that it strives for homeostasis. It wants to retain its steady state, its baseline normality. The body exists in a homeostatic equilibrium. Visualize it like a seesaw that is equally weighted on both sides and parallel to the ground. That's what the body always strives for. So whenever you introduce something into the body that it didn't put there on its own, something that it doesn't expect, we refer to these as exogenous compounds. When you put something in the body that doesn't normally belong there, the body immediately sets about trying to get rid of it. It's just a protective mechanism. The process of trying to get rid of it results in a bunch of changes to the drug. And that's what pharmacokinetics is, what the body does to the drug. So when you put something in somebody, whether you inject it or give it orally or rectally or whatever the case may be, immediately the body will start doing things to it. A series of things. It will absorb it, it will distribute it, it will metabolize it, and ultimately it will excrete it. And that's what pharmacokinetics is. And this does change across the lifespan because it's very dependent on physiology. So the physiology of the neonate and the infant, say, is very different than the physiology of the geriatric patient. We also have to consider the physiology of pregnancy, which is different than the physiology of the lactating, breastfeeding mother. So all of those things are factors when we think about the pharmacokinetics of the drug. Pharmacogenetics. This is more of a 21st century term. Everybody's talking about pharmacogenetics and pharmacogenomics and genetic testing, and we'll talk about all of these things. But I would caution you that because these are new-ish concepts, they tend to be very trendy, and like any new thing, are probably a little bit overused. So genetic testing definitely has its place. It can definitely improve drug therapy for certain patients. But right now we have to wait for the pendulum to settle a little bit. It's sort of overshot too far in the wrong direction. But the terms are what interest us now. Pharmacogenetics it's the genetic predisposition to how we absorb, distribute, excrete, metabolize. It also speaks to the genetic variation in how a drug affects a patient. This is in the gene code. Pharmacogenetics is in the gene code. So people do have physiology that results in a different approach physiologically to medication. This is why some people, like you can have two patients who appear to be matched in every way. They might be the same age, the same gender. Like you could have two 50-year-old females. Let's say you have two 50-year-old females. They are both 5'5". We'll give them all the fives. 50 years old, 5'5". They may have the same apparent medical history. Maybe they have hypertension, osteoarthritis, whatever, the traditional middle-aged stuff. And then you give them, and they have the same disease, and you give them the same drug in the same dose, and they will respond very differently to it. And that is, at least to some extent, a result of pharmacogenetics, how they are genetically programmed to utilize that drug, absorb it, distribute it, metabolize it, and excrete it. And we really do have to consider this. And this is a big player in why sometimes when you give people a drug, they just don't respond the way that you think they would. Sometimes they appear to be like totally unresponsive. Other times they'll tell you that it makes their symptoms worse. And sometimes you give what you think is a small dose and the patient says like, oh my gosh, I can't take this stuff. It's killing me. They feel like over-medicated. And this is very often, at least in part, a consequence of pharmacogenetics. Pharmacogenomics is sort of like the maturation of pharmacogenetics. Pharmacogenetics is your genetic predisposition or your genetic tendency. Pharmacogenomics is how that tendency is expressed. The more that we learn about genetics, and it does get a little bit beyond the role of this course, but the more that we learn about pharmacogenetics, we realize that, yes, you may have a genetic predisposition or a genetic tendency, but lots of things contribute to how that tendency is actually expressed, including numerous environmental factors, lifestyle factors, other medications. We see this real commonly in mental health and psychiatric medications. When you give people psychiatric medications for an extended period of time, those medications change the concentration of chemicals in the brain that subsequently actually alter the way that the genetic code is expressed. So, like I said, I know we're getting a little bit far afield here. I really just want you to have some level of comfort with these terms so that when we use them, if you and I use them in a conversation, we're using them the same way. Pharmacodynamics, what the drug does to the body. Pharmacokinetics, what the body does to the drug, really in an effort to get rid of it. Pharmacogenetics is what is your genetic predisposition to the properties of pharmacodynamics and pharmacokinetics. And pharmacogenomics is how is that pharmacogenetic tendency expressed? How does it actually impact the way the body responds to a drug? Because pharmacogenetics is often influenced by other non-genetic factors like environment, lifestyle, stressors, physiologic stressors, emotional stressors. All of these can influence how a gene trait is expressed, and that's what pharmacogenomics is. So just a couple of terms for you to get used to there. The other thing that really is the foundation of the discussion of pharmacology is receptor agonist theory. So every science has a theory. I'm sure that you've learned lots about nursing theory and mid-range theories, and I have to confess, I don't really know what the trend is in nursing theory right now. That was really never my area of expertise, but I do know that every science is based in theory, and so is pharmacology. And I guess if you were taking a class, like if you were working on a degree in pharmacology, you would be assaulted with a lot more of the theoretical foundation, but you're not. So since this is the only, well, I guess in this program, I should say it's one of 2 pharmacology courses that you will have. We don't have to spend weeks and weeks on theory, but we do have to talk about this very basic one because it also really underlies our whole discussion of drug therapy, and it is known as receptor agonist theory. And just like the slide says to you, pharmacologic agents, when we prescribe for a patient a prescription medication, it is either an agonist or an antagonist. Either it produces a response or it blocks a natural response from happening. And every drug falls into one of these 2 categories. Every drug is either an agonist or an antagonist. An agonist binds to a receptor on or within a cell and results in some sort of biologic response. It makes something happen, whereas antagonists don't. Antagonists have no inherent act of their own. Antagonists bind to a receptor on or within a cell, and they block the action of an agonist, usually a naturally occurring agonist. So remember a few minutes ago, I was using the example of the beta adrenergic agonist and the beta adrenergic antagonist. Classic example. A beta adrenergic agonist like albuterol or epinephrine is a chemical that binds to beta receptors and actually causes things to happen. In the heart, it will increase contractility, it will increase heart rate, thus increasing cardiac output, also increasing the workload on the heart. Whereas a beta adrenergic antagonist doesn't do anything in its own right. All it does is bind to beta receptors in the heart, blocking the action of naturally occurring epinephrine. Right? You see the difference there? An agonist causes a response. An antagonist does not. An antagonist has no inherent action on its own. It just blocks the response, or it blocks the action of a naturally occurring agonist. And many drugs that we prescribe to people are antagonists. So it's not that they do anything, it's that they block a normal, natural body response. So we do have to take a few minutes to ponder the concept of receptors, agonist, and antagonist. I mean, this is a classic lock and key theory, right? The lock is the receptor, the key is the agonist, and something plugging up the lock, like a piece of gum, would be the antagonist. So the receptors themselves, the things that an agonist or an antagonist bind to, can be located anywhere within a cell. Many of them are located within the cell membrane itself. Others are contained inside the cell on the nuclear membrane, and others are contained on structures within the cell. But a receptor is clearly an integral part of this theory. The drug that you give to a patient has to have something to bind to. Whether it's an agonist or an antagonist, it has to have something to bind to. Receptors may be enzymes, nucleic acids, or membrane-bound protein. These are different cellular structures. Enzymes, remember, are things that usually accelerate a response. They catalyze a response of some sort. So an agonist may bind to an enzyme receptor and turn it on and activate it. Receptors may be in the nucleic acids, in the nucleus itself, or, as I say, embedded into a cell membrane or the cell membrane. Embedded into the cell membrane. I'm trying really hard not to advance these slides too quickly, because I know that some of the narrative gets cut off at the very end. So if that happens, sometimes I'll usually make it up on the next slide like I will right now. And then other times it'll sound like there's a couple seconds of dead space at the end of a slide. It's just because I'm still trying to navigate. After 25 years of teaching, I'm still trying to figure out how to advance my slides with the right timing. So please bear with me. Anyway, here's a good example of a membrane-bound receptor. So you all remember studying the cell membrane in Biology 101. The cell membrane is that amphipathic lipid structure that separates the intracellular environment from the extracellular environment. And it is critically important. What is inside a cell is very different than what's outside a cell. Just for instance, the inside of the cell, the pH is 7.0. The outside of a cell, the pH is 7.4. If the intracellular acid managed to find its way out into serum, we'd be in big trouble because we can't survive at a pH of 7.0, at least not for very long, without bicarbonate fusions. By the same token, the intracellular potassium is about 140 milliequivalents, whereas the extracellular potassium is about 4 milliequivalents. And you probably remember that we couldn't survive for very long if our extracellular potassium, if our serum potassium was 140 milliequivalents, right? So separating intracellular from extracellular environment is critically important. And this cell membrane does it beautifully. It keeps things very separate. The only things that get through this membrane are things that the membrane allows through. And one of the ways that we can get things through a membrane is if an agonist binds to a receptor and then allows channels to open. So this is the cell membrane, the amphipathic lipid molecules. You have hydrophilic heads, these purple balls, and hydrophobic tails. Remember, hydrophobic is water repelling or water hating. So these hydrophilic heads interface with extracellular fluid out here and intracellular fluid in here. But the hydrophobic lipid tails in the middle are what really keep the two contents separate, the two sides of the membrane separate. And as I say, the only way through this membrane is if the membrane allows it. One of the ways that we can let things through a membrane is if an agonist binds to a receptor and causes a channel to open or facilitates the movement of something from one side of this membrane to the other, usually from the outside in. If a substance wants to do anything in the body, if a drug wants to do anything in the body, it's got to have some way to interface with the cell membrane, because inside the cell is where everything happens, right? Outside the cell and the extracellular fluid, that's really just a highway system. It just carries stuff around. But all the good stuff happens in the intracellular space. And so this membrane becomes very important. How do things get through it? Or how do things make stuff, how do things on the outside make stuff happen on the inside? And these membrane-bound proteins are very important in doing that. So there's your membrane-bound protein. This is clearly the receptor. This would be the lock. Here looks like an example of a key. When the key binds to the lock, if it's an agonist binding here, it will cause a response. If it's an antagonist binding here, it will block a naturally occurring response. And here's just another view of it. So remember that not all agonists and antagonists have to be drug therapy or pharmacotherapy. We have a whole variety of endogenous agonist and antagonist. For instance, insulin. Insulin is a little protein. It's a little water-soluble protein. It doesn't move readily through the cell membrane on its own, and yet we know that it is critical to catalyzing the uptake and storage of fuel sources, right? And so the way that it works is that insulin binds to an insulin receptor, and when it binds to the receptor, it causes a, so yeah, this is the example of outside, right? So here is where it's not bound, it's trying. Insulin is little purple balls. When it binds to the receptor, you can see that it catalyzes a series of responses inside the cell that ultimately result in the uptake of glucose, the uptake of proteins, and the storage of three fuel sources, proteins, what do you call them? Glucose and fat. I don't want to get too far afield here, but I probably should mention that this lipid barrier is very fat side. I mean, it's fat, right? The lipid is fat. And so fats can diffuse through it without an opening or without a channel. Fatty substances can move right through here easily with no extra help at all. And so with this example of insulin, the three fuel sources are glucose, fats, and proteins. Glucose and protein are water soluble. They can't move through the membrane on their own, but fats like triglycerides are. So when you eat a meal that presumably has glucose, fats, and triglycerides in it, insulin is released from the beta cell, right? Insulin binds to insulin receptors. When insulin binds to the receptors, it causes a series of reactions to occur that allow glucose channels to open. I know you can't see it here, but glucose channels open in this membrane. Protein channels will open in this membrane. Now, you don't need fat channels because fat can move through the lipid barrier on its own. But once you open those glucose and protein channels, then all three fuels can get in the cell, and then insulin further goes on to facilitate storage of all three fuel types. So yes, we got a little bit far afield here, but I really do want you to understand the principle of an agonist and an antagonist, because when we throw around drug names, I mean, we are virtually always referring to an agonist or an antagonist. So it's important that you know the difference between the two. To that end, in case it slipped your mind, in case you forgot, an agonist receptor union produces a biologic response. There is an active biologic response. An agonist is a compound, either endogenous or exogenous, in other words, naturally occurring or artificially introduced, that binds to a receptor to produce a biologic response. And insulin is a good example of all of these things. Insulin is an agonist. It causes a response. Insulin can be either endogenous or naturally occurring, or it can be biologically engineered insulin that we make in a lab and give to a patient. Either way, insulin is insulin. It binds to insulin receptors and it causes a series of reactions to happen. So when you give somebody an agonist, the more agonist you give, the greater the response you'll get, until either the maximal response is reached or receptors that are available are saturated. In other words, I mean, both of these things can happen. Sometimes there are only X amount of receptors. So you give more and more and more agonist, and ultimately the receptors are full, and then the rest of the agonist you give isn't doing any good. Or sometimes before you even get to that point, you get 100% of the response that you are looking for. So a full agonist produces a 100%, I cannot speak this morning. A full agonist produces a 100% biologic response. A partial agonist cannot produce 100% response, even at very highest doses, because either the receptors are saturated, or clinically, in some cases, the patient can no longer tolerate any higher amount of agonist without adverse consequences. I do want to point out at this point that here is where the science of pure pharmacology versus the science for healthcare providers differs a little bit. And I had somebody ask me this in another class, so I wanted to take a moment to make the point. In the very purest sense, a 100% response in the lab is like literally 100% of the response that you can achieve with the agonist. I mean, there's no attenuating factor. But in a human, when we refer to a full agonist or a 100% response, we're typically talking about a clinical response. So again, to go back to my example of the beta adrenergic agonist, when we give, say a patient's having an asthma attack, and we give a patient an albuterol treatment, and then maybe it gets them some relief, but not 100%. So then we give them another albuterol treatment. And then another. I mean, sometimes when people are having significant exacerbations, we sit there for an hour and just keep giving them nebulizer treatments. If the patient gets to the place where their symptoms are completely resolved and they feel completely back to normal, maybe the emergency room example wasn't the best example, but let's talk about a patient who maybe is at home. Their asthma flare is a relatively mild one. They use their albuterol inhaler and they feel fine. They have no complaints. They feel like it's totally taken care of. That would be considered a 100% response, even if in the lab we didn't have full relaxation of bronchial smooth muscle. I hope that makes sense. So if you were studying pharmacology to be a pharmacologist, you would consider it a full agonist if you had complete relaxation of the bronchial smooth muscle and a complete saturation of receptors. In clinical practice, we consider it a full agonist if the symptoms have resolved fully, even if in purest terms, every single receptor is not saturated. So a full agonist for us is a 100% clinical response. We have produced everything we're trying to produce. If you give somebody a medication for hypertension, and that medication reduces their blood pressure to goal, you get them exactly where you want them to be, we would refer to that as a full agonist. Even if in a pure pharmacology setting, in a lab setting, you didn't get complete reduction or complete arterial dilation. Similarly, a partial agonist cannot produce a 100% response even at very high doses. And from a clinical perspective, we consider a drug a partial agonist if we've given the patient as much as we can and we still don't have full symptom control. Perhaps we have completely maxed out the dose of the ACE inhibitor, the calcium channel blocker, or the diuretic. We've given them the highest dose we can give, and we still don't get good control of blood pressure. Or we've given them the max amount of albuterol we can, which according to evidence-based guidelines is repeated albuterol treatments for 1 hour. If at the end of that hour we still don't have adequate bronchodilation, then the drug has acted as a partial agonist. So the short version, full agonist gets us clinically 100% of the response we're looking for. A partial agonist does not, even in the highest doses that we can give it. Oh, look, I got all excited and said it ahead of myself, so I don't have to repeat what's on this slide here. There's just another example here in terms of the opioids. So opiate agonist, again, yes, morphine, Dilaudid, whichever, pick your poison in terms of opioids. You may give as much as you can give, the highest dose you can give without causing respiratory suppression, we'll say, without being unsafe. If the patient doesn't have complete pain control, we would call this a partial agonist. Now, I also feel compelled to point out at this point, we don't always necessarily anticipate or achieve complete 100% reversal of symptoms. In the world of pain management, that's often not possible. What we're looking for is to get the patient to the best place where they can manage their pain. So that's not to say that a partial agonist is a bad thing or an inadequate thing or a substandard thing. It's just another state of being. So for our discussion, if a drug clinically is a full agonist, it reverses symptoms or achieves the response we want 100%. If it doesn't, if we give a drug at maximal doses and we can't get 100% of the response we're looking for, it would be considered a partial agonist. And a partial agonist is better than no agonist. I mean, a partial agonist sometimes is the best we can achieve and the best we can hope for. And so, like I said before, an antagonist has no effect of its own. All it does is bind to a receptor and block a biologic effect of an agonist. And an antagonist can either block or reverse the effect of a naturally occurring or endogenous agonist, or it can block the effect of an exogenous or artificially administered agonist. Either way, an antagonist blocks the effect of an agonist. Now, just like agonist can be full or partial, so can an antagonist, basically. Sometimes an antagonist can completely block the effect of the agonist, and other times it can't completely block it. It just makes it less potent, less available. And so agonist and antagonist, they both can either do their job 100% or not. So going back to the examples I keep coming back to, don't worry, soon we're going to move on to something else here. But this is an important concept, and I really hope everybody has a better grasp of it when we're done with this first part of the lecture. So beta-adrenergic antagonist, I've already given you that example. Angiotensin II receptor antagonists, we use these very commonly to treat CHF, to treat hypertension. And of course, opiate antagonists, Narcan, naloxone, naltrexone, these are all things that block the effect of an agonist. Now, the difference, the concept we don't have with an agonist, with an antagonist, some antagonists are competitive and some are non-competitive. And this also is a point that you really want to get your hands around because it does have some implications for prescribing. A competitive antagonist competes, logically, for the same binding site as the agonist. A non-competitive antagonist does not. So there's a picture here that probably will help. Picture is always worth 1,000 words, right? So let's see. This is like the same, we're looking at the same example here in 3 different snapshots. So first up, what do we have? So the first example, here's a receptor, and here's an agonist. Here it's referred to as a ligand. You know, in science, we always have to have 4 different names for the same thing. So here's the receptor embedded in the cell membrane, and here's the agonist. And the agonist binds to the receptor, and now it looks like this, right? Now it's going to do something. That's why it's green. So that's what I mean. Like this is a view of the same receptor. This one is unbound. This is when the agonist binds to it. When the agonist binds, it produces a response. It turns green, stuff happens. That's what happens when an agonist binds to a receptor. Now, consider the act of an antagonist. The competitive antagonist competes for the same site. So again, here's your receptor. Here's the agonist we were just looking at, but here's the competitive antagonist. They're both trying to get in the same spot. A good example of this is morphine and naloxone. Naloxone is a competitive antagonist. Now, if the competitive antagonist has a higher affinity for the receptor, and antagonists usually do, if the competitive antagonist has a higher affinity, if the magnet pull is stronger, then the antagonist gets in the binding site, which is what you see here, and if the antagonist blocks up the binding site, the agonist can't get in it. Nothing happens. You have no green here, right? Nothing is going on. This would be a competitive antagonist. A competitive antagonist competes for the same binding site as an agonist, and when the competitive antagonist binds, the agonist cannot. There is no signal. Nothing happens. Another approach that the body has to attenuating responses is that sometimes we have non-competitive antagonist. A non-competitive antagonist binds to a different site. So you can see the example here. Here's your same, we're looking at the same example. Here's a receptor. Here's the agonist binding site. But now this example has a different antagonist binding site. This is a non-competitive antagonist. They're not binding for the same place. The agonist binds, and then the antagonist binds over here. And when the antagonist binds, it weakens or attenuates the response of the receptor. And here's what it looks like. The agonist is still bound. There's still going to be some kind of a response, but the antagonist has also bound to this membrane, and it's going to attenuate or reduce the response of the agonist. So what you get is a partial signal, right? Or a partial act. Notice how this is a lot greener than this one. This is green, 100% go. There's no antagonist blocking the response. But down here, the non-competitive antagonist blocks the response to the agonist, so you only get a partial signal or a partial activity. Make sense? I hope so. If it doesn't, take a few moments to think about it again. So agonists and antagonists. Agonist can be a 100% full agonist or a partial agonist. Antagonists may be either competitive, where they completely block the response to the agonist, or non-competitive, where they partially block or inhibit or attenuate the response to the agonist. And again, in physiology, it's not that one is better or one is worse. There is a role for both of them. Like, for instance, and maybe I'm getting ahead of myself here. Nope. This is the end of this discussion, so I'm just going to give you one example here. Opioids. So you know, if somebody overdoses on opioids, we give them naloxone. Naloxone is a competitive antagonist. It completely displaces morphine or Dilaudid or whatever. It completely kicks off the agonist. And if you've ever given somebody naloxone, they wake up. They are up. I mean, it's very quick. The competitive antagonist does the job, kicks the agonist off the site, boom, there is suddenly no more agonist activity, and patient wakes up, usually screaming, because at least in the hospital setting, they were in pain. They needed a opioid. We just gave them too much of it. So that's a competitive antagonist. Now, an example of a non-competitive antagonist is an angiotensin receptor blocker that you have probably given given people for hypertension or CHF, like I said. So it's a non-competitive antagonist. We don't want to completely block the effect of angiotensin 2. Angiotensin 2 is important. It's what helps maintain a blood pressure and keeps us alive. We have to have some angiotensin 2, but in some patients with hypertension, there is maladaptive or overactivity of angiotensin 2, so we can attenuate it by giving a non-competitive antagonist. So in that case, we still get some vasoconstriction, we still get some response to the angiotensin 2, but it is attenuated by the angiotensin receptor blocker. Agonist and antagonist, you do want to be familiar with them. The next concepts on your handout are efficacy and potency. So these are pretty simple terms, but they're two different things. And if you don't really know how they're defined, it's easy to be confused. It's easy to just mix them up. What it comes down to is that efficacy is the effect. That's why I guess it's efficacy. Efficacy is the response that a drug can produce. It's the impact that it has clinically on the patient. If you take something for blood pressure, and it really, really drops that blood pressure down, it is considered highly efficacious. Whereas potency is the amount of drug required to produce the effect. Potency doesn't speak to what the drug does to the body. It just speaks to how much of the drug you need to get a response. And so, like I said, it's easy to mix them up. I hear students all the time speaking in such a way that implies they think potency is actually efficacy, like talking about something is really potent, something really did this or really produced a lot of that response. And that's not the way we use the term. Potency is the amount of drug, efficacy is the response. So, yeah, how well a drug produces a response. You know that, for example, with pain, we often have people rate their pain on a scale of 1 to 10. So if a medication reduces headache pain from a 10 to a 5, like you've got a really bad migraine or cluster headache or something like that, you give them the best drug you got, and they went from 10 on a pain scale to 5 on a pain scale, well, then we said it has 50% efficacy. Not that efficacy really needs to be numerical. I just, I have a very black and white brain, so I use numbers to help illustrate the point. But if in this case it cut the pain in half, it cut it to half, didn't completely eliminate it, but it cut it in half, we would say it had a 50% efficacy. Now, if you gave somebody medicine for headache pain, say they have a pretty bad tension headache, you give them 2 Motrin and the headache is gone, then that would be a 100% efficacy, and that would be awesome. So yes, there is just something to break up the monotony of looking at words and listening to me. If any of you suffer from headache syndromes, you can probably identify with how profound they can be. But I'm really just trying to make the point here. Efficacy is how well the drug works. Now, potency is different. Potency is how much of the drug is required to achieve the desired response. It really doesn't matter unless higher doses of the drug can be toxic or cause dangerous adverse effects that the patient can't tolerate. So for instance, when we refer to potency, if 4 milligrams of hydromorphone produces the same pain relief as 10 milligrams of morphine, well then the hydromorphone is more potent. That's all it means, is that the hydromorphone is more potent. It has nothing to do with efficacy. If they both reduce pain to the same extent, they are equally efficacious. It's just that hydromorphone is more potent and getting there. So I hope this one makes sense to you too. When you finish school, if you go out to work in the primary care setting or the outpatient setting, and you're in an environment where, drug reps can come detail you and tell you about their drug and tell you how good it is and why you should use it on your patients, you will hear these terms like potency and efficacy missed up. Like they will emphasize how something is so potent and what a great thing that is. And actually, it's really not, provided that the dose of drug falls within a reference range normal. Again, potency is not about how well it works. Potency is just about the dose that is required to get you there. And so, to summarize that concept, the fact that one drug is more potent than the other doesn't make it any better in any given circumstance. Efficacy is the quality that we use to determine how well a drug works. If I have a tension headache, I can either take 400 milligrams of Motrin or 1,000 milligrams of Tylenol, right? not to be advocating for any one drug or the other here, but typically, you buy ibuprofen over the counter. Motrin is a popular brand. It comes in little 200 milligram tablets and you usually take 2. If you buy Tylenol over the counter, it's either going to be regular strength, which is 325 milligram tablets, or extra strength, which is 500 milligram tablets. So I myself always buy the extra strength stuff. So if I have a headache, I'm going to take either 2 Motrin to total 400 milligrams or 2 extra strength Tylenol to total 1,000 milligrams. If they both get rid of my headache completely, they are equally efficacious, but the Motrin will have been more potent because it takes less of it to do it. Keep in mind that you really can't compare potency. You can't, it doesn't matter that one is more potent than the other unless the efficacy is the same. So to finish up this example here, if on Monday I had a headache and I took 2 Motrin and the headache went completely away, and then on Tuesday, I got the headache again, but I don't have any more Motrin, so I take 2 Tylenol, and the headache went completely away. They were equally efficacious, but the Motrin was more potent. Now suppose that, same thing, on Monday I had a headache, I took 2 Motrin and the headache went completely away, and then that was my last Motrin. So the next time I got a headache, I had to take 2 extra strength Tylenol, and it didn't get rid of my headache completely. It may have dulled it down, but I still have a little bit of a headache. Well, then they were not equally efficacious, right? The Motrin was more efficacious because it got rid of my headache when the Tylenol didn't. So potency is just irrelevant. It's not even a comparable concept here. It's the efficacy that is comparable. Now, if the efficacy is the same between 2 drugs, then we can say that one is more potent than the other. And that's probably more time than we even needed to spend on that concept. Now we're going to move into something that really is a little less intuitive, but something you really want to get your hands around, and this would be bioavailability. So bioavailability, yes, it really is a critical concept in pharmacokinetics. This is like the key feature of any drug you administer to somebody. We need it to be bioavailable. Bioavailability, by definition, is the amount or the fraction of drug that reaches circulation in a form that is ready to engage in a biologic response. Again, I don't want you to memorize that phrase. I want you to understand what it means. If a drug is going to do anything, if it's going to work in the body, it has to be bioavailable. It has to get into serum and then be available to do stuff. If a drug reaches circulation in a form that is not bioavailable, it can't do anything. It has no action if it's not bioavailable. There are many drugs that we give people that are highly protein bound, which means when they get into circulation, the drug is going to bind to a protein. And if it's bound to something, it's not available and it can't do its job. So not only does a drug have to reach circulation, right? This is where pharmacokinetics becomes important. Not only does it have to reach circulation, but then once it gets there, it needs to be in a bioavailable form. That's the piece of the drug that's actually going to do something for the patient. Bioavailability is influenced by so many things, and these are the things that we're really going to talk about pretty much for the rest of this discussion. Bioavailability is, number one, influenenced by the route of administration, right? There are many ways to give somebody a drug: orally, rectally, transdermally, parenterally, whether IM, IV, or sub-Q. Like, there's all sorts of ways to get a drug into a body, but then it has to cross a variety of barriers to get into circulation. If you give somebody something by mouth, it's got to go through the whole absorption, digestion, distribution piece. If you give somebody something rectally, it's got to be absorbed through the rectal mucosa. If you give somebody something subcutaneously, it's got to be absorbed in the vasculature of the subcutaneous bed. If you give it IV, you're dumping it right into circulation. But any other mechanism, there are going to be some barriers that the drug has to go through to get to circulation. And every barrier typically will decrease the amount that actually gets to systemic circulation in some way. So let's see, I probably just said half of what's on these next slides because I do get excited and go ahead of myself. Okay, first up, route of administration. Yeah, I did just say this. The lesser the number of roadblocks, the greater the bioavailability. This is why often when we give something IV, we give a much lesser dose of it than we give to somebody PO, right? I mean, you know how this goes. If you give somebody morphine IV, you're going to give something like 2 or 4 milligrams to start. But if you give it orally, you typically will go much higher than that, like, maybe 10 or 20 milligrams PO, because it's got to go through all the roadblocks to actually get to systemic circulation. So, yep, IV is the easiest way. You dump it right into circulation. When you inject something intramuscularly, the muscle bed is highly vascular. So the only thing the drug has to do is be absorbed into all of those blood vessels. IM is probably the next best way to minimize barriers and maximize bioavailability. Obviously, orally has to go through all sorts of degradation before it gets into systemic circulation. A very specific impact of oral administration is GI motility. So, the gut moves in theoretically a predetermined time frame. If all things were equal and life was perfect, you would ingest something, it would be mixed in your stomach, it would be distributed into your duodenum, it would very slowly move through the small bowel and it would be absorbed, and then it would get to the large bowel where water is absorbed, and then what's left over would be formulated as feces and excreted. And in a perfect world, this has a very defined time frame here, right? Like in a perfect world, it results in a bowel movement every morning at 7 a.m. Except that the world is not often perfect, and so lots of things can impact GI motility. So if GI motility slows down, then things sit in the stomach and the duodenum and the ileum longer, and that can either increase absorption or decrease it. It really depends on the drug. By the same circumstance, if something happens to increase motility and really jack up the peristalsis in your gut, then that can have an impact on absorption, either increased or decreased. You just can't predict. You can't predict it. And it's because some drugs need to be broken down and acidified and degraded by enzymes for optimal absorption in the gut. So if GI motility slows down, they actually sit there longer and absorption would be increased and it would increase bioavailability. Other drugs, if they sit there too long, they get broken down into inactive or like not useful forms. So if GI motility slows down, then the drug just sits there, breaks down, and by the time the molecules are absorbed, they don't do any good. So decreased ability, it can either increase, or decreased motility can either increase bioavailability or decrease it. By the same token, if GI motility is too quick, sometimes that can increase absorption by allowing absorption to happen before the drug is broken down by acids and enzymes. Or if the drug is better absorbed with optimal breakdown, then slowing down motility can maximize absorption. So either way, the real takeaway message from this slide is GI motility will have some effect usually on bioavailability, but we can't make a direct correlation. We can't say, oh, if motility slows down, it will increase availability, and if motility speeds up, it will decrease availability, because that's not the way it goes. All you want to keep in mind is if the patient has something going on, like they are constipated for some reason, maybe as a consequence of drug therapy, their motility is slowed down. If they're on pain medications, for instance, or anticholinergic drugs, motility will slow down. That can have some impact on the way a drug works. By the same token, maybe they have gastroenteritis or they're taking medications that are cholinergic and speed up the gut. It's going to have some impact on absorption. I remember when I was a brand new nurse, really, it was like one of my very first jobs as a bedside nurse. So this was a very long time ago. I was working in an ICU, and I had a patient who was getting drugs through an NG tube, and so she's getting her antihypertensive medications for her NG tube, and her blood pressure just kept creeping up, up, up. It wasn't, the drugs weren't working, and so when I did my morning assessment, I noticed that her bowel sounds were very, very slow. Like she sounded like one tinkle away from an obstruction, so her motility was just really, really slowed down, and so later that morning, the resident, the charge nurse, maybe she was still my preceptor. I might have been that new. But anyway, the charge nurse or the nurse that I was like reporting to, the resident, who used to be a nurse, and myself were sitting at the desk, and the resident was looking at this patient's vital signs chart and talking about how her blood pressure was going up and up. And I mentioned that her bowel sounds were like really, really slow and almost non-existent. And did that have something to do with why her oral drugs weren't working? And I remember that the resident and the more senior nurse kind of looked at each other like, hey, why didn't we think of that? And as it turned out, they did convert her drugs to a parenteral mechanism while they figured out how to get her motility back on track. And it really did make a difference. So it was just one of the few times. I mean, back then, I didn't even really know what I was talking about. I was just trying to piece things together. So it's one of my success stories that I always like to share. Believe me, I have lots of not success stories that I won't bother to share because why would I? Well, that's not true. Sometimes some of my biggest flubs are a good teaching tool for you all so you don't make the same mistakes. So believe me, I will throughout the course tell you about my flubs. But this was one circumstance where it's just such a classic example of how this can make a difference. And that patient's particular circumstance slowed GI motility, decreased absorption of her antihypertensive medications, and so they just became less and less effective. Okay, so that's enough about that. Other things that can happen in the gut are drug-drug interactions. So remember that the pH of the gut tends to be very low. The gut is an acidic environment so that it can break down fuel sources, it can break down nutrients for optimal absorption of sugars, fats, proteins. It will also facilitate absorption of, minerals like calcium, vitamin B12, stuff like that. So the gut is usually very acidic. And when pharmaceutical companies make medications, they assume that if they're making something for PO administration, they assume that it's going to be absorbed in an acidic environment. PO drugs are formulated that way. Sometimes it makes a big difference and sometimes it doesn't. Some drugs really do require a very acidic environment for absorption. So if the patient is on another medication that raises the pH of the gut, it will seriously impact absorption of that drug. So antacids, over-the-counter antacids, good things like good old-fashioned Tums, Zantac that you can buy over the counter, that kind of stuff, or the things that we prescribe to raise the pH of the gut, like Protonix or Prevacid. There's a whole bunch of them out there now. These all raise the pH. Also, bile acid binding drugs. I mean, the name tells you the story. They bind acid in the gut. Drugs that bind acid decrease the effectiveness of the acid, so ultimately the pH of the gut goes up. And if you are also giving a medication that really needs acid for absorption, well, it's just not going to absorb well. And there are some examples here given for you. Antifungal drugs, the tetracycline family, they really need an acidic environment. So if the patient is also taking like a proton pump inhibitor, you will find that those drugs are less effective. Same example here for antacids and bile binders. These are things that actually bind the drugs themselves in the gut. And, warfarin, we will come back to this 100 times as an example of drug interactions on every level, but this is just one of them. So we have to consider when we're giving something orally, how it is impacted by other things that are given orally. Let's see. I think this is everything I just said. Interactions that occur in the gut. Oh, yeah, these are just some examples of drugs that can be greatly impacted by drug-drug interactions in the gut. So, and I know like this probably all makes sense to you theoretically, but it's so easy to forget. It's when you have to put it all together and actually apply it to patient management, and you're seeing a patient in follow-up and you're like, man, why isn't this drug working? Why isn't this doing the thing that we said it was going to do? And sometimes it's because they're taking something else that either interacts in the gut with that drug or changes the motility of the gut, which will then impact absorption of the first drug. Let's see. Oh, so the next thing, yes, is interactions that occur in serum. So interactions that occur in serum, we're not talking about the gut anymore. Now the drug presumably has gotten past the gut and it's actually in the blood itself. And there's lots of interactions that can occur in blood that can decrease bioavailability. Remember, what we're talking about here ultimately is bioavailability. What are all the things that can keep a drug from being available in serum to do its drug? So yes, most drugs are most active in the non-bound form. So when a drug in serum is bound to something else, well, then it's going to make it inactive. Protein is one of the most common things that drugs will bind to in serum. We often talk about a drug's protein binding affinity, or its affinity for protein, or its percent of protein binding. Co-administration of 2 or more drugs that are normally highly bound to protein will obviously result in greater activity of one or both of them. And the classic example that I'll come back to 100 times is Coumadin and ibuprofen. So the thing about Coumadin and ibuprofen is that they are both highly protein bound. If you look them up, you will see that in the description of Coumadin, it is usually described as being about 97% protein bound. Ibuprofen is often described as being about 99% protein bound. So that means that when you give somebody a dose of these drugs, only a very small fraction of it is actually free, unbound, and bioavailable in serum. If you give somebody 10 milligrams of Coumadin, assuming 10 milligrams of Coumadin makes it into serum, 97% or 9.7 of that 10 milligrams will be bound to protein and not free to engage in a biologic response. Only 0.3 milligrams will be free to engage in a biologic response. But then, eventually, the pharmacokinetics of the human body will metabolize that 0.3. It'll metabolize that 3%, get it out, it will excrete it, and then there will be no free unbound Coumadin in circulation. So the body will liberate 3% of the remaining 9.7. So now you might have, I don't know, like 9.4 bound to protein and 0.3 free, unbound to engage in a biologic response. And then as the body metabolizes that, the 9.4% or the 9.4 milligrams that's bound to protein will liberate 3% of it. So it's like protein binding is a distribution mechanism. Protein binding holds on to the drug and just liberates the fraction that the body needs to do its job. That's the impact of protein binding. Now with ibuprofen, which is about 99% protein bound, if you give somebody 400 milligrams of ibuprofen, well, what's 1% of 400? 4. So only 4 milligrams is going to be free to engage in a biologic response, and the other 396 will be bound to protein. And when that first 4 milligrams is metabolized and excreted, then the protein will liberate 1%. So protein binding, visualize it as like a distribution mechanism. If a drug is 99% protein bound, at any given point in time in the body, whatever dose is on board, only 1% will be free to engage in a biologic response. So now you've only got so much protein, right? You can see where we're going with this. So let's use albumin as an example. You've only got so much albumin. A normal albumin is a level is 4. So if you've got X amount of albumin and then you give the patient 2 highly protein bound drugs, there's only so much protein available for binding. So one of these drugs is going to draw the short stick, and there will be more of it free to engage in a biologic response. So protein binding is one important piece of the discussion. Affinity is another one. How strong is the pull of this drug and protein? A drug that is highly protein bound with a comparatively lower affinity for protein is the one that's going to get displaced and stuck out in circulation, free to do its job. And that's one of the things that makes Coumadin so difficult to manage. It's one of the reasons that virtually every drug has the potential to make Coumadin more active or to potentiate Coumadin. While Coumadin is highly protein bound at 97%, it's got a relatively low affinity for Coumadin. So if you give any other drug that's protein bound and that drug has a higher affinity for protein, it's going to kick Coumadin off the protein binding sites, and the Coumadin is just going to be free, unbound, and free to engage in a biologic response, which is to inhibit clotting. Oh, and so again, I get excited and I just start narrating without actually advancing the slides to do it. So the next couple of slides say everything that I just said. Many drugs bind to proteins. Remember, when they're bound, they are not bioavailable. Albumin is most prevalent, but yes, there are others. Albumin's not all there is. And so when a drug is bound to protein, it is inactive. It is in storage. It is the percent that's not bound to protein that's going to be free to do its job, whether it's to bind to a receptor or cross a membrane or whatever it does. It's only the unbound part that is free to engage in a biologic response. Yes, and so this is one you might have to listen to once or twice. You might have to chew on it for a little bit. The percentage of protein binding remains constant. When two drugs that are highly protein bound are given simultaneously, the one with the lesser affinity will be more abundant in its free form. Again, the percentage of protein binding remains constant. So if Coumadin is 97% protein bound, that means 3% of Coumadin on board at any given time is free to engage in a biologic response. So I gave you an example of 10 milligrams. 10 milligrams of Coumadin on board, 9.7 is going to be bound, 3 milligrams will be free. But as the body metabolizes and excretes that 3 milligrams, then there's only 9.7 milligrams in the body. So 3% of it will be liberated, unbound, to produce a biologic response. And when the body excretes that, then the remaining will liberate 3%. And it just like piecemeals it out so that always, however much is on board, 97% is bound, 3% is free. But you can see the problem here. If the drug doesn't have a high affinity for protein, then any other drug that comes along with a greater affinity will occupy all the protein binding sites. The drug that doesn't have the high affinity is just liberated out into circulation and will just do its job to excess. This is why Coumadin is just so difficult to manage. It's the combination of high protein binding and low affinity. And yep, that is everything that I just said. Protein binding is a matter of storage. Another concept in bioavailability is absorption. So absorption refers to the ability of a drug to reach circulation and then cross the membrane at its target tissue or cell, or that should say either bind to the membrane or cross the membrane. Absorption is really the ability of the drug to get to its site to do the thing that it's supposed to do. And circulation really is a huge factor. I mentioned before that if you give something IV, you dump it right into circulation. No barriers, no problem. If you inject it into a muscle is highly vascular, so there's lots of vessels for the drug to be absorbed in. So IM administration is like the next best thing to IV, right? Subcutaneous tissue doesn't have nearly as much vasculature. Subcu fat is just mostly fat. There's definitely some vascular, some capillary spread in there, but not nearly as much. So if you give a drug that is designed for subcu administration, it's designed assuming that it's going to be deposited into a lump of tissue that doesn't have a whole lot of vessels in it. Right? So if you take a drug that's designed for sub-Q administration and dump it into a muscle, well, its absorption is going to be increased. There's going to be greater absorption than was anticipated when that drug was formulated. That's assuming that everybody's circulation is normal. But now imagine that you give a drug IM. So when that dose was recommended, when the drug book says, oh, give, 2 to 4 milligrams IM, it assumed that the muscle would be well perfused, but maybe somebody's muscle isn't well perfused. Maybe you have a patient who's got a long history of hypertension and their capillaries are just like sclerosed and atherosclerotic and they don't work very well and they don't have good circulation. You deposit that drug in that muscle and it's not going to be absorbed nearly as well as you thought. On the other hand, suppose somebody's circulation or perfusion is exaggerated. Suppose maybe they're taking vasodilators, right? Maybe they're on nitroglycerin. And so the vessels in their muscles are really, really dilated, which really maximizes or optimizes drug absorption if the drug is dumped into muscle. So my point here being that circulation is an important part of how a drug is absorbed, and it can be either increased or decreased depending on the patient's physiologic circumstances. And it's not just muscle, right? There is circulation in subcutaneous tissue, there is circulation in the gut, there's circulation in the rectum, there's circulation in the dermal surface. So even for transdermal administration, every place you put a drug presumes that circulation to the absorptive site is, quote, normal. So if circulation in the absorptive site is abnormal, either greater than expected or lesser than expected, it's going to influence the way a drug is absorbed. And a classic example of this is, say you have a little old lady who doesn't weigh 100 pounds, and you inject a drug in her muscle, you think it's going to be like the tiniest dose, right? Because she's like this little old lady, and you inject a drug and it does nothing at all. Maybe it's just because her circulation is poor that the muscle is not well perfused and it just can't get absorbed to where it needs to be. Then take like the 250-pound bodybuilder, like rock solid guy with all this muscle, and inject the same amount of drug in his muscle, and he's snowed. Maybe you give the little old lady 2 milligrams of morphine in a muscle, does nothing for her. You give the same great big strapping man 2 milligrams of morphine in his muscle, and he is snowed. Why? Because his muscle is extremely well developed and perfused, whereas a little old lady, maybe she's had hypertension for 30 years and she's got like almost no circulation left. So you have to consider circulation when we think about how much drug we give to a person. How will it be absorbed in that area? How effective is the circulation? So circulation is a key factor. And yep, everything I just said is on this slide too. So to summarize this piece of the conversation, bioavailability is the term we use to refer to the drug actually reaching its target in an unbound state and free to engage in a biologic response. And there are lots of things that can impact bioavailability, right? Absorption, distribution, GI motility, drugs that impact GI motility, drug-drug interactions that occur in the gut, things that occur in serum like protein binding, and then of course the circulation to the area where you anticipate that the drug will be absorbed. All of these can have some impact on bioavailability, and they're not always so predictable. It's not always necessarily the way that you would think, like the little old lady versus the big strapping guy. So consider all of these as they impact bioavailability. The next thing we need to talk about in terms of bioavailability is pharmacokinetics. Okay, so at the beginning of the discussion, I alluded briefly to pharmacokinetics and said that generally it refers to what the body does to the drug, how the body absorbs it, distributes it, metabolizes it, and then finally eliminates or excretes it. And now I want to pay a little bit more attention specifically to metabolism. I mean, they all matter, but we need to spend the most time, at least right now, with metabolism. So we have already alluded to absorption. Remember, earlier on in the discussion, we were talking about how unless you administer a drug intravenously, any other mechanism of administration requires some crossing of some barrier, whether it's in muscle and you just have to cross capillary barriers, or whether you administer it PO and it has to get past salivary enzymes, the acidity of the gut, the enzymatic population of the gut, getting across the epithelial membrane. I couldn't think of the name of the cells that line the gut. But anyway, there's a bunch of barriers to administering something PO. Distribution refers to how the drug is distributed among various body compartments. Some drugs are very water soluble and they distribute highly in water compartments. Others are very fat soluble and they tend to make a home in fatty areas of the body. But metabolism is the thing that I really want to talk about first. And then we will finish up our conversation with a brief discussion of how drugs are eliminated from the body. I mean, no big mystery there. They either come out of the urine, they come out of the skin, they come out of the the GI tract. Either end, perhaps, but we do have some considerations, obviously, about renal function and stuff like that. But I'm getting ahead of myself. Actually, right now, I really do want to talk about metabolism. So there are a variety of things that influence pharmacokinetics, and they're all listed right here. And most of these have their greatest impact on drug metabolism. So we have the non-genetic factors. I think you're familiar with all of these, even if you haven't thought about them in quite this way. Um, the age of the patient can influence our selection of drug and dosing based on the ease with which the drug is transported through the body, broken down, and then eliminated. Obviously, organ function matters. Liver function and renal function are the two biggies, right? I mean, just as a function of age, our renal function declines a little bit. And then, of course, those with renal disease have a lesser ability to excrete drugs. So, that matters. That will impact bioavailability. Concomitant therapy. We alluded to this a little bit when we were talking about drugs that alter GI motility. So if you take drug A that needs an acidic environment to be absorbed, and then drug B that raises the pH of the gut, it's going to influence the absorption and ultimately bioavailability of drug A. So that's a concomitant therapy example. And then, of course, there are drug interactions. There are drugs that potentiate each other. There are drugs that inhibit each other. All of these are non-genetic, right? They're patient specific. And then finally, if a patient has an underlying disease, that may impact how they metabolize the drug. For instance, patients with liver disease often will have altered metabolism. Patients with cardiovascular disease or congestive heart failure, they have decreased tissue perfusion, and this will impact bioavailability. So we have all of those that we always talk about, but the genetic ones are the ones that we just introduced into this discussion. And this is the genetic code for things like the enzymes that metabolize drugs, which will be a big part of our conversation today. Those chemicals that transport drugs through serum are also influenced by genes. And the targets, excuse me, the targets of drug therapy, the receptors of drug therapy, to some extent are influenced by the gene pool. So we have a whole variety of factors that influence how a drug is absorbed, distributed, metabolized, and excreted. But like I said, drug metabolism is really our primary topic of conversation for right now. So physiologic metabolism, I'm trying not to read the slides to you, but sometimes it's necessary. Physiologic metabolism, whenever we refer to physiologic anything, we're talking about a normal function, right? Pathophysiologic is abnormal, physiologic is normal. So a normal physiologic metabolism or normal metabolism is the mechanism whereby anything administered into the body is converted to a form that prepares it for elimination. We're talking right now about drugs, but anything you put in the body, like I said, the body strives for a state of homeostasis. Whenever you put something in the body that it doesn't recognize as its own, it will immediately try to prepare for excretion. It just tries to get rid of it. I mean, even on a macro level, I'm sure you've experienced with this. The second bullet point says when the body perceives the presence of something exogenous, it immediately begins to prepare it for elimination. Think about it. If you put something in your gut that doesn't belong there, health, like regular food that's not spoiled belongs there, right? But say you ingest food that has been sitting out too long, the buffet's a little late on the buffet, and you get a virus or bacteria in your gut that your body recognizes as an invader. What does it do? It immediately jacks up motility, both ends usually. You'll have a bilateral explosion here through the mouth in the way of vomit, through the anus in the way of diarrhea, because your body is trying to get it out. If you even just get a little tiny splinter or a little piece of glass in your foot, what happens? First thing that happens is your body tells you it's there. I mean, it is amazing how consumed you can become by like a 1 to 2 millimeter splinter in your foot. But it hurts. You're aware of it. You become very focused on getting it out. If you can't get it out, or you don't get somebody to get it out down there with magnifying glass and tweezers, the body is going to begin to implement mechanisms to get it out. You're going to have inflammation. It's going to push it to the surface. You're going to have increased vasodilation to liberate all of those complement and healing factors, and your body will push it out eventually. It's not going to feel good along the way. It'll be a pain, but your body will get it out. If you get something in your eye, what happens? You immediately start to tear to flush it out. And if you're not able to flush it out naturally, your body will most definitely make you aware of the fact that something is in your eye, and you won't rest until you get it out. Like, these are just examples everybody can identify with. The same thing goes on excuse me, the same thing goes on in vivo, inside, where you're not aware of it. You put something in there that the body doesn't like, and it immediately triggers a whole series of events to try to get rid of it. This is what drug metabolism is. The body likes that steady state, right? So when something gets in there that doesn't belong, basically all hell breaks loose until you get it out. Now, of course, you can't appreciate this because it's happening inside the body, but it's those same mechanisms that happen outside the body. The way I always remember this phenomenon is I think of my ex-husband number two. So this was one of those ex-husbands. I mean, good guy, really do like the guy, but he, on Sundays for football time, he had to be in front of the TV. The remote had to be right there. There had to be like the glass with ice for the bourbon and Coke right there. TV on, remote next door. Remote for the TV right next to him. The, what do you call it? What's that thing I'm trying to think of? Like the recliner, to make the recliner go out. And there had to be ice in the glass for the bourbon and the Coke. That was homeostasis. And as long as all of that was in place, we could watch 3.5 hours of football and life was good. But if any one of those things was out of whack, if any one of those things wasn't there, if we couldn't find the remote, if the chair wouldn't recline, oh, heaven help us if there was no ice, there was an ice emergency, like everything stopped and all the energies had to be focused to getting things back to the way they were supposed to be. And as soon as the remote was there, the TV was on, the chair was reclined, and there was ice in the glass, life just went back to steady state. That's what happens with drug metabolism. You introduce something, even as benign as a Tylenol or a Motrin, whatever. When the body recognizes that it doesn't belong there, it incites all sorts of mechanisms to get it out. And one of the biggest things the body has to do is convert the drug to a form that can be readily excreted. So notice the second bullet point here says, in order to prepare a drug for elimination, the body tries to convert it to a water-soluble form. This is the form that is readily excreted by the kidney. So let's see what the next slide says. Yes, okay, so remember that body compartments are either lipid, water, or bone, which nothing really can dissolve in. So we're most interested in lipid compartments and water compartments. So like fat is all, like subcutaneous fat that keeps us warm and has all sorts of endocrine functions. Fat is a lipid. Cell membranes are a lipid. Lots of organelles are made out of lipids. So there's lots of lipid substances in the body. And one of the things about the lipid structures is that they often act as a barrier separating water compartments. We talked about this a little bit earlier. And most importantly right now is that the cell membrane is a lipid. So when you give somebody a drug, if you want that drug to actually do anything, it has to be able to interface in some way with a lipid because the lipid is the gate to the cell. And if the drug can't act on a cell, there's really no point in taking it. So you got to figure every drug that is manufactured for administration has some level of ability to interface with fat. It will have some degree of lipophilia. Some drugs are very lipophilic. Once they get a hold of fat, they're not leaving. They have really long half-lives and they can hang around forever. Some drugs have very little lipophilia. Like they're able to just hang on to a piece of fat by the skin of their teeth. They'll be excreted very quickly. But every drug has some degree of lipophilia because if you're lipophilic, you can engage the fatty structures in some way. So if the body wants to get rid of that drug, the thing that it does is try to change the chemical structure of the drug so that it will not be lipid soluble or lipophilic, that it will be water soluble or hydrophilic. Because if it's hydrophilic, it's got no teeth. It can't hang on to any fat. It's just going to circulate through serum and get eliminated through the kidney. Most mechanisms of drug metabolism exist to take the lipophilic structure of a drug and convert it to a hydrophilic form, and that's how it is excreted. So we looked at this already, right? This is your cell membrane. These are the hydrophilic heads, but these are the lipophilic tails in the middle. And once a drug gets its teeth in there, it can cross the membrane, it can do something, or even if it just binds to a receptor in the membrane, it's got to have some degree of lipophilia. Some drugs immediately cross right through this lipid. They're very lipid soluble. They cross right through here and life is good. So if the body wants to get rid of that drug, it's got to get it while it's out here in the extracellular space, make it go from lipophilic to hydrophilic so that it can just get excreted straight up in the kidney, which is, of course, the most common mechanism of drug excretion. You remember how powerful the barrier is, right? The difference between lipid and water. I can't think of, there's a name of that, and for the love of me, I can't think of what it is right now, but I'm sure everybody knows what I'm talking about. This is one of those experiments that you usually do in like high school biology. You pour the fat into the water and then they immediately separate. So if you've got a drug that you're trying to get into this fat or on the other side of this fat, it's got to have some degree of lipophilia. All drugs will. Now, drugs that have just a little bit of lipophilia, the body can metabolize and excrete them very easily, and then we just have to give them more often. These are like your QID drugs. You know, some drugs just barely hang on. The reason that we dose drugs with varying degrees of frequency is that we're just trying to chase the body. We put a drug in, the body kicks it out. We try to add another dose before the body kicks it all the way out, thus raising serum levels. So the body kicks it out, we add more. The body kicks it out, we add more, but we try to add it a little bit faster so that slowly and steadily the levels climb. And then by the fifth or sixth dose of a medication, the body has reached a steady state where it's eliminating it, we're administering it, but it stays within a normal therapeutic range in serum. Anyway, drugs have to have some degree of lipophilia. So in order to be active, it will have some degree of lipophilia. As you can see, I have this habit of getting excited and talking ahead of myself, and then the next 3 or 4 slides chase it. Anyway, I guess better to hear something 2 or 3 times than not hear it at all, right? So in order for a drug to be active or bioavailable and active, it has to have some degree of lipophilia. The more lipophilic, the longer it hangs around and the longer the half-life. Remember, the half-life is the amount of time it takes to reduce the serum level of a drug by 1/2. So if you start out with 10 milligrams of drug in serum, and then in 4 hours you're down to 5 milligrams, the half-life is 4 hours. That 5 milligrams in another 4 hours will be down to 2.5, and in another 4 hours will be down to 1.25, and then beyond that, I can't do the math. But the idea is the more lipophilic, the more fat-loving, the longer the half-life. The shorter the half-life, that means that the drug is not as lipophilic and we have to give it more often. Lipophilic compounds are not filtered at the nephron, right? The nephron is able to filter water-loving stuff, hydrophilic stuff. So in order to excrete a drug in the kidney, pharmacokinetic mechanisms will convert it from a lipophilic form to a hydrophilic form. Very important point. So these are the 4 primary mechanisms by which drugs are metabolized in the body. 4 different mechanisms, and the names almost in every case tell you what they do. Some drugs are metabolized by way of oxidation. In other words, the body adds oxygen to the compound. This changes the structure of the compound and it makes it water soluble. When something is oxidized, it tends to be water soluble. Some drugs are dehydrogenated, or hydrogen ions are taken off of them and it changes their level of hydrophilia. Other drugs are hydrolyzed. Water is pulled off of them, H2O, 2 hydrogens and an oxygen. So the names there tell you what's going on. But the single most common mechanism by which the human body metabolizes drugs for excretion is what's known as the cytochrome P450 mechanism, or cytochrome P450 degradation. Cytochrome P450 refers to a family of enzymes, and there's a bunch of individual enzymes in this family. Think of cytochrome P450 as like the last name. So there's a bunch of enzymes in this family. Remember, enzymes catalyze a reaction. They promote a response. And so these enzymes in this family promote the degradation or promote the conversion from lipophilia to hydrophilia of most drugs. I think 2/3 of all prescription medications are metabolized by cytochrome P450 enzymes. And so there's a real safety issue here, because if you have any issue, any anomaly or any abnormality in your cytochrome P450 mechanisms of metabolism, then drugs don't metabolize and they can accumulate in serum. And if it's a drug that can be toxic in higher levels, well, you can see that it could be a real problem. But anyways, right now we're just interested in how this works. So remember, again, from from your chemistry class or your biochemistry class, that all of the compounds of the body are structures built from the elements. Remember the periodic table of the elements in General Chemistry 101 or something back, when you were like a freshman in college? We have a whole bunch of elements, and I'm sure there's more now than there was when I was in school. But the naturally occurring compounds in the human body seem to be built largely on carbon, nitrogen, oxygen, and hydrogen. Now, of course, there are other elements in the body, like phosphorus is one, iodine is another one. Like there are, of course, others, but the four core compounds, or rather the four core elements from which compounds are built are carbon, nitrogen, oxygen, and hydrogen. So by way of example, glucose, C6H12O6. If you had to, just write out the formula for glucose, it would be C6H12O6. 6 carbons, 12 hydrogens, and 6 oxygens. And here they are. And this structure forms glucose. So we've got like 1, 2, 3, 4, 5, 6 carbons. We've got 1, 2, 3, 4, 5, 2 hydrogens here, 6, 7, 8, 9, 10, 11, 12 hydrogens, and then oxygens should be 6 of them. 1, 2, 3, 4, 5, 6. C6H12O6. And when it's put together just this way, it's glucose. Now, if you just move one thing, if you just move one compound here, it's not glucose anymore. Now, I went back to listen to that last slide for a reason, and I realized that you can't see the arrow that I'm moving around the screen, so hopefully you were able to follow along. But going forward, I will try to use something that's got some color to it if I need to do any pointing or anything like that. So my apologies. I was thinking you could see the arrow, but I guess on the recordings you can't. Anyway, the point I really just wanted to make is that every compound in the body and all drugs are structures that are assemblies of elements. And carbon, nitrogen, oxygen, and hydrogen are very commonly found organic elements in the body. And when they are put together in a certain particular way, then they are a single compound. But if you just change one thing about it, if you move one bond, move an oxygen, move a hydrogen, move a nitrogen, it can completely change the structure and function of that compound. Now, this is the elemental structure of atorvastatin. Now, it's common that just the angles represent a C, so you can't see the C, but hopefully you can see me drawing this. I know I'm bad at it, but all these little angles are C's. And you can see where nitrogen and hydrogens are thrown in. There's oxygen here, fluorine. So there are certainly other things, but this is foreign to the body. The body doesn't recognize it. And as soon as it goes in the body is going to try to excrete it. And one of the things that it will do is try to change just the tiniest bit, just move one bond, change one thing, move a hydrogen, get rid of an oxygen, move one thing, and it will make it an entirely different compound. And in the case of drug metabolism, it often converts it to a hydrophilic compound so that it can be excreted. But the idea is everything starts out as an assembly of elements. And if you just change the tiniest thing about it, you can completely change the structure. So as I mentioned before, any of those four processes, oxidation, dehydrogenation, hydrolysis, and cytochrome P450 metabolism may be used. And by the way, it's not unusual for several mechanisms to be used on one drug. Any or all of those processes collectively can change the elemental assembly of a drug, convert it to a hydrophilic form, and prepare it for excretion. So just to give you an idea of the difference that one new element can make, let's look at the next slide. So this is C2H6, right? 2 carbons, 6 hydrogens. This is ethane. This will kill you. This is very, very volatile and very dangerous. And if you ingest it, it can kill you. If you just add 1 oxygen to it, so now it's C2H6O, this is ethanol. And ethanol, if used responsibly, after it is grown in the Carneros region of Northern California and fermented and processed just the right way, it can actually be a very enjoyable dinner drink or a drink after dinner in the form of a Chardonnay wine. Now, again, of course, I would absolutely 100% encourage responsible use, not excessive use. Don't use it when you're driving or operating heavy equipment or doing anything that requires any sustained mental or physical dexterity, because that's not a good idea. But my point being, what a difference this oxygen can make. This can go from volatile and deadly in tiny amounts to very enjoyable and pleasant when used appropriately in moderate amounts. Point is, it's just the O here, the oxidation, that makes a difference. So oxidation is one mechanism by which we can convert a drug from a hydrophilic form to or rather a lipophilic form to a hydrophilic form. So here you have cyclophosphamide. You see the drug compound. It is very common in scientific notation for RH to be used to represent like any drug, like just any drug would be RH. So in a discussion, in a equation or elemental reaction, RH means drug compound, any drug compound. And you go from RH, introduce molecular oxygen, you wind up with the oxidized form, and this is much more water soluble and much more easily excreted in the kidney. That's just an example of oxidation. All you do is add an oxygen, literally. Dehydrogenation, you take off hydrogens. So if you look at this compound and if you count every element in it, I know I'm moving my cursor around, but you probably can't see it. If you look at this drug and count every element in it, what you'll see over here is that hydrogens were taken off. So there are a grand total of 6 hydrogens less on this side, on side X, than there were over on the left. This drug has been dehydrogenated, and it completely changes its ability to interface with fat and water. And then finally, hydrolysis is a mechanism by which 2 hydrogens and an oxygen are removed. So if you compare the compound on the left, we'll put an L here, with the compound on the right, what you'll see is it's missing an oxygen and 2 hydrogens. You're just left with one of the hydrogens. It has been hydrolyzed, and it makes it very different. So the names, for the most part, tell you what's going on, but excuse me, the cytochrome P450 family is the last one we're going to talk about, and it actually is the most common mechanism. So yes, like your slide says, this is the primary mechanism of drug metabolism in the body, and cytochrome P450 interactions are responsible for more clinically significant adverse drug reactions than any other cause. That makes cytochrome P450 a really important safety thing that we need to be on the lookout for. You'll notice that it is referred to as the cytochrome P450 cascade. It's because there are a series of reactions. This is a cascade of events that has to occur where you start with a lipophilic compound and you end with a hydrophilic compound. The cascade is described as a series of oxidation reduction reactions. And ultimately, the drug comes out in an oxidized form, but every step along the way is important, as you can see in the next picture. So this is the best representation I've ever found of this cascade for our purposes, like what I wanted to illustrate for you here. And it's kind of funny because it's in French, but it doesn't really matter. Don't worry about the title. We can all figure out what this means. But the bottom line is you start out with RH, right? So point 1 here. This is the beginning. The drug is introduced to the body. It's injected, it's swallowed. I'm trying to draw a, what do you call it? A arrow, but I did a bad job. Let me try this. Okay. RH, drug goes into the body. This is step number 1. When it first is introduced to the body, it is complexed with a low spin iron molecule, right? So you see your iron. Here, we're going to label that number 2. And the drug and the iron are drawn together and creates yet a different compound. This is a drug that is complexed with iron. So now it's high spin, which means the elements on the outer edge of the shells are spinning, literally spinning high, and they are volatile and they attract other compounds. In this case, it will attract an electron. That's step number 4. And when the electron is introduced into the equation, the electron is introduced in the form of hydrogen ions. Hydrogen ions are electrons in this discussion. So when you introduce the hydrogen, it changes things yet again. And now you have a different compound. And this different compound is the drug with Fe2. There's only a 2 shell valence here. So now this particular compound in 5 is attracted to oxygen, or rather oxygen is attracted to it. So in step 6, you see oxygen being pulled into the party. And oxygen really changes things here. Oxygen is volatile. So you have a compound that is sort of constantly undergoing change, like in and out, on and off. You see the reaction here goes back and forth. That's item 7. This on and off, this volatility attracts yet another electron, which is a hydrogen ion. Oh, that's step number 8. Now again, I'm not very good at drawing freestyle here. Let's try again. Step number 8 is drawing in the electron. Well, good enough for our discussion. So now you have yet an entirely different compound that I'm going to draw in a box here, and we'll call it 0.9. The character of this compound, it's a free radical. There's like extra shells on the oxygen hanging around here. This attracts hydrogen, 2 hydrogens. We'll call that step 10. And when the hydrogens get pulled in, what they do is complex with one of these oxygens, and it hydrolyzes the compound, splits off a water, which we'll call number 11. And that leaves yet this brand new compound you see here as item 12. And when this happens, the low spin iron splits off, and what you are left with is oxidized drug, item 13. And this oxidized drug is much more water soluble than the initial drug that entered the cascade. So then you might be saying to yourself, why do you have to go through all that? Why can't we just take RH, add an oxygen to it, and call it a day? And the answer is that the body always has control mechanisms in place to make sure that things are attenuated, to make sure that you exist in a steady state. If you just, as soon as you took in a drug, you added oxygen to it, you would go from fully active to completely inactive. It would be all or nothing. There'd be no control. There'd be no attenuation. So you would either be toxic or subtherapeutic. It would either work hugely or it would not work at all. And so everything in the body really occurs in a cascade. We don't always enumerate all the steps, but think about like the clotting cascade, think about complement activation. Excuse me. Like every reaction that happens does have multiple steps. And the cytochrome P450 cascade is a series of oxidation reduction reactions. You add electrons, which means you reduce it, and then you add oxygen, and then you add electrons again, and then you hydrolyze it, and in the end you come out with oxidized compound, which is readily excreted by the kidney. And that's what we're talking about when we talk about cytochrome P450 metabolism, or the cytochrome P450 cascade. So if you accept the premise that the cytochrome P450 cascade is a series of reactions that exist to metabolize drugs, and like I said, 2/3 of all prescription medications are metabolized this way, those medications that are metabolized by this mechanism are known as substrates. The substrates are subject to this enzyme cascade. They need this enzyme cascade to be metabolized. So a substrate drug is subjected to this mechanism for metabolism. Easy enough, right? Except that other medications will actually inhibit some of the cytochrome P450 enzymes. And further, there are other things, other drugs and other substances that can actually induce cytochrome P450 enzymes. So think about it. If you take drug A, and drug A is a substrate, it will be metabolized by this enzyme family. And then you take drug B, which inhibits this enzyme. What do? You inhibit the enzyme that metabolizes drug A. So drug A doesn't get metabolized. Excuse me. So it accumulates in serum and the levels go up, up, up. And the concern is toxicity. And if you take drug A, which is a substrate, and then take drug C, which induces the enzyme, well, then the problem is you exaggerate activity of the enzyme, you promote metabolism of the drug, and it doesn't get a chance to do its job, and its serum levels are subtherapeutic. So that's what's significant here. And in retrospect, I'm sure that's exactly what the rest of these slides say. I said it too fast. Yeah, when you give two substrates together, nobody really cares. I mean, 2/3 of all drugs are substrates of this enzyme family. So sure, you may have a patient who takes multiple medications. Almost certainly, more than one of them will both be substrates of this cascade. No problem, not a big deal. The problem is if you give a substrate and an inhibitor, the inhibitor inhibits the enzyme that metabolizes the substrate, and the substrate can accumulate and become toxic. Conversely, if you give a substrate and an inducer, the inducer accelerates activity of the enzyme metabolizes the substrate drug too quickly, and the concern is subtherapeutic levels of the substrate. It just doesn't get a chance to do what it's supposed to do. So let's see, yes, numerous therapeutic agents are substrates of the cytochrome P450 oxidation reduction system. A variety of others are inhibitors, and a variety of others are inducers. Yes, I already said this. So in case it slipped your mind from the first 3 slides, everything this slide says is the same thing. Okay, so if you need to go back and listen to those last few slides a few times, please do so, because before we move on, I really want you to be comfortable with the conversation about the fact that cytochrome P450 is a family of enzymes that metabolizes drugs, and the drugs that are metabolized by those enzymes are referred to as substrates. And other drugs, unfortunately, can inhibit cytochrome P450 enzymes. And if you give an inhibitor with a substrate, you inhibit metabolism of the substrate, and the substrate could become toxic. On the flip side, some medications are inducers. So if you give a substrate and an inducer, the inducer accelerates metabolism of the substrate, and it may appear to be subtherapeutic. So that's that. But now, to further complicate the issue, are the pharmacogenetic and pharmacogenomic influences. As a consequence of the gene pool, some people just metabolize faster or slower than others. So you see 4 descriptions of metabolizers here. This isn't my interpretation. This is how we commonly break them down in the literature. We have ultra metabolizers, extensive metabolizers, intermediate metabolizers, and poor metabolizers. So extensive metabolizers is like, that's considered to be population normal. I'm going to put a 1 next to it here. And the name, like, extensive, to me sounds like exaggerated, but nobody asked me to consult on the nomenclature. So extensive metabolizers is considered the quote normal population. So if you open a drug book and the drug book says, okay, you should start this drug like at this dose, and then you can escalate to this dose, and you should not exceed that dose, like all the normal ranges that are recommended, they presume that the patient is an extensive metabolizer because the quote average patient is an extensive metabolizer of a drug. But there is a small subsegment of the population who are ultra metabolizers as a consequence of the gene pool, whereas other people in the population may not metabolize as well as a normal. We call them intermediate metabolizers, and then some people are flat out poor metabolizers. This is why you can have 2 people that have exactly the same circumstance, same age, height, BMI, disease, renal function, liver function, all of those non-genomic or non-genetic influences on metabolism. You can take 2 people who are matched in every way, give them the same dose of the same drug for the same disease, and they react very differently to it. Some people, the drug won't appear to affect them at all, and others will appear toxic on the same dose, and you say, how can this be happening? The person that doesn't appear to be affected at all is probably an ultra metabolizer. We'll label that too. Ultra metabolizers, they metabolize drugs so fast, they just don't get a chance to work. And then the poor metabolizers, which we'll label 3, they don't metabolize well at all. So you give them a dose and they can't get rid of it. Give them another dose, and before you know it, it's on top of the first dose and they're toxic. And to give you an example, I practice in psychiatry, and I do have patients that need to be on benzodiazepines sometimes. Even though I know benzodiazepines are considered evil right now, some people do need them. And so I have one patient, man, he's a man about 200 pounds, like middle-aged guy, you would think, and he actually works in a rather physical line of work, and you would think he's pretty healthy, which he is physiologically speaking, but he needs to be on Xanax occasionally. And what he takes is one half of a zero point 0.5 milligram tablet. So I gave it to him. I gave him a 0.5 milligram tablet, and I said, hey, the first time you take it, when you don't have to go to work, take it at home in the evening, see how it affects you. He took a half a milligram, and it like snowed him. So then the next time he took half of that tablet, and he still felt like he could barely function. So then he took one half of the half. I think this turns out to be 0.125 milligrams of alprazolam, and this like 200 plus pound middle-aged man, that's just enough to control the anxiety without making him feel snowed. I have other patients, like older, late middle age, like 60-something-year-old women with anxiety who takes a 2 milligram tablet and it barely helps her. And, a lot of times people think, oh, the 2 milligram one is drug seeking, dependent, whatever. I mean, all of that may or may not be true in some circumstance, but the fact is she doesn't go through life being snowed. So clearly, she has a higher ability to metabolize it. She's metabolizing it more quickly. So that's just one example. We see the same thing with people with, the statins like atorvastatin, rosuvastatin, stuff like that, just all of the medications. Some people, as a consequence of their gene pool, can metabolize very quickly, others barely metabolize at all, and then some, we'll call them number 4. Where's number? Can't leave number 4 off. Some people just don't metabolize as efficiently, so they typically do very well on lower doses of a medication. I'm going back to my psych practice here because it's the one I do most often these days. If I might have a patient who does extremely well on, like I put them on a 50 milligram tablet of Zoloft, which is on the low end, right? Zoloft comes in 25s, 50s, and 100s. And usually I figure a patient's going to need 100 or so milligrams of it. But sometimes if people are a little bit nervous about starting off on meds, I'll give them a 50 milligram tablet and say, take half of it for the first week. And I've had people come back to me and say, listen, after I took that one half a pill, like it just made all the difference. I just been taking a half ever since. And they get symptom control on 25 milligrams of Zoloft. And I have other people who are taking 100 milligrams and barely get any effect at all. So again, you can see the difference here between ultra metabolizers, intermediate, and poor metabolizers. And if you can't see it, perhaps this can help a little bit. Sometimes a visual just makes things a little bit clearer. So we got 4 people here. Curve A is the poor metabolizer, B is intermediate, C is extensive, and D is ultra. So we're going to start out with all of them at the same point, right? On day 1, when they're just starting therapy, all of them start out with a drug level of 0 milligrams, right? There's no drug in their body. They all start with the first dose, right? We give them 1 dose. Well, the poor metabolizer is the person that doesn't metabolize well. Their level climbs very quickly because they're not breaking it down and getting rid of it. By the time we give them a second dose, they haven't gotten rid of most of the first one. We give them the third dose, they haven't gotten rid of most of the first 2. Very quickly, the poor metabolizer's level goes up, 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 and they will eventually become toxic on a traditional dose. Whereas the intermediate metabolizer, we give them their first dose. They metabolize it better than the poor metabolizer, but still not great. Their levels climb pretty quickly. And so even on a comparatively low dose, pretty soon they just fall like just under the toxic range here. Whereas your extensive metabolizer, who is your quote normal patient, you give them a normal dose. After a couple doses, well, not a couple, after 5 or 6 doses, they achieve a steady state. And they fall out here like just above the minimally effective dose. So it's effective, but not causing them any side effects or any adverse effects. And then you've got your ultra metabolizer who takes it and they metabolize it almost as fast as they take it. And you keep giving them more and more and more, but they keep metabolizing it. They never even reach an effective level. The drug just is subtherapeutic unless we really, really, really crank it up. So hopefully that gives you a bit of a visual of what we're talking about here. It just explains why people seem to respond very differently. It's not that people always have inappropriate expectations, or they want something different, or they want more drug. Sometimes they just metabolize it to a greater or lesser extent. Similarly, not everybody is a hypochondriac. Not everybody is like imagining their adverse effects. The people that are poor and intermediate metabolizers, they are more sensitive to drugs. They will have higher serum levels, and it wouldn't be a shocker if they had more adverse effects than your average extensive metabolizing patient. So these next few slides are just examples. I don't expect you to memorize them or remember them. I promise not to say like, which of the following is a cytochrome P450 inhibitor? Like, I don't expect you to necessarily know all that. Just conceptually, these are some commonly encountered cytochrome P450 inhibitors. Now, remember I said cytochrome P450 is the last name. This is a family. This is a family, and within that family are a bunch of first names like 3A4, 3A5, 3A7, 2C9, 2D6, 2C19, 1A2. There's a bunch of individuals. I think of cytochrome P450 as like the umbrella, and then the individual isoenzymes are spokes coming out from that umbrella. The significant thing is that it's the isoenzyme that really matters. So if you take a substrate of 3A4 and an inhibitor of 3A4, you are probably going to get toxic levels of the substrate. Whereas you can take a substrate of one along with an inhibitor of the other, and it's not nearly as big a deal. Like, I could take a substrate of the 3A4 enzyme and an inhibitor of the 2D6 enzyme, and they like don't have that much to do with each other, so it's a much safer proposition. It's like if you take a substrate of a 3A4 enzyme and then an inhibitor of a 3A4 enzyme, it's like you're trying to get out of a room and somebody's shutting the door. You can't get out. Whereas if you take a substrate of a 3A4 and then an inhibitor of a 2D6, it's like you're trying to get out of the room and somebody shut the window. Well, who cares? You'll just walk out of the door, right? How's that for an analogy? Probably not that great, but I hope it helped a little bit. Anyway, these are some examples of inhibitors. Here are some common substrates. And yes, to make it even worse, a drug can be both a substrate and an inhibitor. It can be a substrate and an inducer, like some drugs induce their own metabolism. It's just a mess. Right now, I just want you to understand the differences among substrate, inhibitors, and inducers, and what happens when you combine them. But look at all these drugs we use every day. Now, these are inhibitors of a different isoenzyme. And yes, there are drugs that inhibit more than one. Like I think we saw amiodarone on the inhibitor list for the 3A4, 5, and 7, and it also inhibits 2D6. These are common substrate. 2D6, very prevalent in psychiatry. And then there are some other subtypes that aren't as prevalent with respect to prescription medications and therapeutic medications, but they do pop up every now and then. Where I've seen the 1A2 be significant is that, excuse me, methadone is metabolized by the 1A2 enzyme, and nicotine induces this enzyme. So if people smoke when they go on methadone, they metabolize the methadone faster and they need higher levels to work. And there was actually a famous case about a guy who was on methadone maintenance for, managing heroin addiction. And he was on methadone maintenance for a long time. And by all accounts, he was really doing well. He was compliant, no problem. But then all of a sudden he overdosed. He became like obtunded and wound up in the emergency room. And it wasn't that he overdosed or he used another opiate. It was that he stopped smoking. And if you stop smoking, you stop introducing the inducer. So the enzyme isn't induced, so it doesn't become as active. So you need less drug as a substrate because you're not metabolizing it as efficiently. So that's just one example. So we will visit this concept again and again, but for right now, I just want you to understand that cytochrome P450 enzymes are a mechanism of metabolism. Their purpose is to prepare a drug for excretion, that the majority of prescription medications are substrates or metabolized by these enzymes, yet there are other medications that can both inhibit and induce them, and then understand the impact that that will have. Now, I guess probably the last concept of metabolism we need to talk about is the first pass effect. So the first pass effect, what is it? Philosophical question here, almost 2 hours into the discussion, right? What is the first pass effect? So when you take something orally and it gets absorbed through the GI tract and it gets passed into the portal venous system and it winds up passing through the liver before it gets out into circulation. And of course, the liver is the organ of drug metabolism. So most orally administered medications are heavily metabolized before they even reach systemic circulation. That's what the first pass effect is. It refers to the fact that most orally administered drugs go through the liver, the organ of metabolism, before reaching arterial circulation. Okay. If a drug is administered in an active form, hepatic metabolism will decrease the amount of active drug before it even reaches circulation. Remember about bioavailability, right? Bioavailability is the amount of drug that reaches systemic circulation in a form that is free, unbound, and can have a biologic effect. Well, we were just talking about how metabolism changes the structure of the drug to prepare it for excretion. So if an oral agent passes through the liver before it even gets into circulation, it's a pretty safe bet that its bioavailability will be diminished, which it will, which is why we give a much higher amount of drugs orally in most cases, not all, but in most cases we give more drug orally than we would if we gave it intravenously, because we are compensating for the fact that the oral administration has this first pass effect where it goes through hepatic metabolism before it even reaches circulation. That's fine. But the last thing I'd ask you to consider here is that some drugs are administered to the patient orally in an inactive form referred to as prodrugs. So they're given inactive and they require hepatic metabolism to convert them to an active form. So if you take a drug in a prodrug form, it requires liver metabolism to activate it. So clearly then, in the patient with impaired hepatic function, this can have some significant impact on bioavailability. What's the second bullet point say? If the liver is suboptimal and a drug is administered in active form, then metabolism will be inefficient and a higher amount of drug will reach circulation. The risk of toxicity is increased. That makes sense? I hope it does make sense, but it's very important that it does, so we're going to say it again. Most drugs are given in an active form. They pass through the liver before they go into circulation. The liver will metabolize them and change their form so that a lot of it will become biologically inactive before it even reaches systemic circulation. So if the liver isn't working quite right, I am having word finding difficulties. If the liver is not working quite right, and all of this active drug is not metabolized to an inactive form, then you wind up with a bunch of active drug in circulation. Bioavailability is increased, and there are concerns about toxicity. But if the liver is not functioning properly, if the liver is suboptimal, and a drug is administered in prodrug form, where that drug needs liver metabolism to activate it, well, then what's going to happen? You give the patient the prodrug, the liver's not working right, the drug won't be activated by the liver, and subtherapeutic levels may occur. So there's a lot going on here between the time that a drug is administered and the time that it reaches circulation in a bioavailable form, and these are just all some of the things that can impact it. Cytochrome P450 metabolism is one, the first pass effect is another, drug-drug interactions in the gut, drug-drug interactions in serum, the barriers that it has to overcome to even get into serum, and everything we've talked about for these whole 2 hours. It all comes down to how much of the drug gets into circulation in a bioavailable form, a free form that is free to engage in a biologic response. That's really the $30 million question, and you want to consider all the things that can impact it. Finally, as we wind down on this conversation, we do have to spend a few minutes talking about elimination. So elimination is just how you get the drug out. So most of the time it comes out by way of urine. It is metabolized as we just discussed, and it comes out in the urine. Sometimes it is metabolized to a different compound that is then used for some other purpose in the body. It is metabolized to an inactive metabolite and then broken down and used for some other purpose. And sometimes you exhale it, sometimes you sweat it out, and sometimes it is recycled through bile. So it's not just urine, although urine certainly is the big one. And so as we look at these last few slides, here are your routes of elimination. Again, the majority of drugs are eliminated through the kidney, but not all. And so you do want to always consider renal function. Impaired renal function very often requires some adjustment of drug dose. Some medications are eliminated through exhalation. Some sweat it out in the skin. Some just come out the other end of the GI tract. And of course, we always have to consider those drugs that are distributed in breast milk for the lactating mother. Routes of elimination must be considered when evaluating the appropriateness of a drug for a patient, like the decreased ability to perspire in the elderly will impact the way that they can eliminate certain medications. But then again, like I said, in case it slipped your mind from the first 10 times I said it, the kidney is the major route of excretion, and so renal flow really is critically important. There's a lot that goes on there in the kidney, you might remember from your pathophysiology class. So some of the highlights here for the impact on renal metabolism and excretion are listed here. Renal excretion occurs through glomerular filtration. So the glomerulus is where stuff gets filtered into the urine in the first place. And then there is tubular secretion and then tubular reabsorption. And these rely on different mechanisms, different pressure gradients. So somebody may have impaired one and not the other. Like, for instance, the glomerulus is where the renal artery first distributes blood into Bowman's capsule, right? This is where urine first gets formed. So glomerulus is based on renal arterial pressure, like blood pressure, systemic blood pressure. There has to be enough pressure in the glomerulus to push stuff into Bowman's capsule, which is appropriately colored yellow because that's where urine starts to form. So you need renal artery perfusion pressure there. But then remember what happens in the nephron. It just concentrates urine. So you see like the squiggly, like the proximal convoluted tubule, then you go down the descending limb, the U shape of the loop of Henle, up to the ascending limb, the distal convoluted tubule, ultimately to the collecting duct. All of these tubules they're surrounded by renal capillaries, by renal arterioles and renal venules, and there is a whole pressure gradient system there that forces waste into the filtrate and facilitates the reabsorption of things that need to come back into blood. And so if a drug is trying to deposit itself in the loop of Henle or in the nephron, but the pressure gradient is too high, the drug might not be able to perfuse from the blood into the urine, so it gets trapped in the blood gets trapped in the blood and can't be excreted. So I don't, it's not my intention to reteach renal physiology here. I know everybody took a pathophysiology course, but I just want to remind you that there is more than one thing. There's more than one factor when we think about renal filtration. Arterial blood pressure is one. If you have a low arterial blood pressure, then you're not going to have good glomerular perfusion. But if you should happen to have like prostate hypertrophy or some obstruction to urinary excretion, then the pressure in the filtrate, the pressure in the convoluted tubules and the loop of Henle can go up, and that increased pressure can make it harder to excrete drugs for waste and distribution. So we will come back and talk about some of this again, I'm sure. But right now, just the most important thing is to remember how critical renal function is when we are considering drug dosing, because renal function is the primary mechanism of elimination. And then finally, speaking of dosing. So the goal of dosing a drug is to maintain a steady state within the therapeutic window. The therapeutic window is that place between the minimally effective concentration and the minimally toxic concentration. In fact, a few slides ago when we were comparing poor metabolizers to extensive metabolizers and intermediate metabolizers and poor metabolizers, you saw two lines there. One said minimally effective and then the other one said minimally toxic. All drugs that we give to people, we want to achieve a steady state where, as long as they're dosed appropriately, the lowest low, the nadir or the trough, stays above minimally effective, but the highest peak stays below minimally toxic. In a 24-hour cycle, we need to keep drugs above minimally effective and below minimally toxic, and that would be a safe therapeutic dose. That's the therapeutic window, and that's the goal. And usually it takes about 5 doses of a drug to achieve steady state. So if it's a drug that we dose once a day, it's not going to achieve a steady state until about 5 days. If it's a drug that we dose QID, then hopefully by the second morning or midday the second day, we will achieve a steady state. About 5 doses to achieve that place where all of the lows are at the same level and they remain above minimally effective, and all of the highs are at the same level and they remain below minimally toxic. This is why dosing is so important. We really have to be careful with patients who just sort of don't like taking it this time, so they take it that time, or they forget, so they take 2. So sometimes that's okay. If there's a really wide range between minimally effective and minimally toxic, there is room to play around a little bit. But if the therapeutic window is very narrow, if there's not much difference between minimally effective and minimally toxic, then you really do need to dose the drug on time. Now, the 5 half-life thing I already mentioned. I know your book says 5 to 6 half-lives. I'll tell you straight up, anybody who's actually listening to this lecture all the way through is getting a freebie on a quiz now, because one of your quiz questions will ask you how many half-lives must pass before a steady state is maintained. And one of the answer choices I think is 5 and another one is 6. And people that don't listen to the lecture, they just read the book. I've had people pick 6, and when I mark it wrong, they say, well, the book said this, and I said, yes, but I told you in syllabus. The book's an excellent reference, but the things that I think are most relevant and most important is what I'm going to pull out and put in your lecture, and your lecture is where your quizzes come from. And so here's a perfect example of it. 5 half-lives, at least for the purposes of this course, 5 half-lives is the answer. Now, when you pass the course, get licensed and go out and practice, if you like 6 half-lives better, then you can use it. But this course is my course, and in my course, we regard a drug as having about 5 half-lives before it hits steady state. So here's what it looks like. You give dose 1, you give dose 1, you get a rising serum level, but then the patient starts to metabolize it. Maybe it's cytochrome P450. Before it gets metabolized all the way down, then you give the second dose. So since they started out from a slightly higher point, when you give the second dose, your peak's a little bit higher, right? And then you metabolize it, and the level starts to drop. But before you metabolize it all, you give the third dose. Now, after the third dose, you start to pop into that minimally effective concentration area, right? See the peak? But you'll start to metabolize it, and you might even poke below the minimally effective concentration, but then you give the fourth dose, and then you reach that peak, and then you can see that by 5 doses, typically, all of the low points, the nadirs, are equal, and they are above the minimally effective line, and the high points are all more or less equal, and they're above the minimally toxic concentration. Now, like I said, a drug that has a really narrow therapeutic window, it's really important that it be taken the way it's prescribed. Like this could be an example of phenetin. Right? The therapeutic window of phenetin is between 10 and 20 micrograms. So there's not much room to mess around. If you don't take it when you're supposed to, if you wait too long, then you fall below minimally effective, the drug won't work, and you wind up having seizures. But if you take it too close together or take too much of it, then you wind up above the toxic line and you can wind up bradycardic. So you really need to, these drugs with narrow ranges, you really need to take them on time. Now, other drugs, for instance, like this one, have a much wider range between minimally effective and minimally toxic. Right? So here you see between 10 and 50 whatever units of measure. So like this is the principle by which a Z-Pak can work, right? So on day 1 of a Z-Pak, you take 2 pills, you take 500 milligrams, shoots you right up into this therapeutic window. So right off the bat, after the first dose, you're in the therapeutic range. You can do it because there's such a wide distance here between effective and toxic. So you give them a whole lot of front loading, and then they start to metabolize it. But then the next day you take the next pill, so you climb up a little bit higher, and then you climb higher, And then by the time they've taken the end of the Z pack, they're really up here like just under minimally toxic. But see, then what happens is it takes so many half-lives to metabolize it down that even though the last dose is taken on day 5, they're still in the therapeutic window all the way past dose 7. So they've got a week of therapeutic drug on board, even though they only took it for 5 days. You can do that when you've got a really wide range between minimally effective and minimally toxic. So that's all I know about that. That's all I know about any of it. And that's the end of this part, this lecture 1. There is a second lecture. Don't worry. I promise it's not another 2 hours. This was a little longer than I thought it would be. But the next one really is just a little supplement about some special populations and a case study to try to give you some clinical relevance. I promise it won't be more than like 30 minutes. So got a 2 hour and 30-minute lecture this week, all told. Well, okay, 2 hour and 37-minute lecture. Please do listen as much, repeat the things that you need to. You have your books and a lot of good external links on the website as a resource. But if you can't find the answers to some questions or something just doesn't seem clear, please do feel free to reach out. And that's all I know. See you in the next lecture.